Welcome, attendees. Welcome. I'm Dan Judge. I'm an advanced heart failure cardiologist at the Medical University of South Carolina in beautiful Charleston. I'm excited to moderate this session, both in my role as a member of the HFSA 2025 Program Committee, as well as a PI for the ATTR-CM clinical trial. This webinar is presented by the HFSA, and it's part of the Cardio Hub series, so we're proud of this educational opportunity. I'm excited to be joined by four of my friends and amyloid colleagues, and I'll introduce them one by one, alphabetically. First, Kevin Alexander is at Stanford University in the Amyloid Center. He's an assistant professor of medicine. Welcome, Kevin. Next is Ahmad Masri, and Ahmad is the cardiomyopathy section head and director of the HCM Center, as well as the cardiac amyloidosis program, associate professor of medicine at Oregon Health Sciences University in Portland, Oregon. Welcome, Ahmad. And third, of course, is Natasha Saraswat, who's an assistant professor of medicine, director of the infiltrative cardiomyopathy program at the University of Chicago, in Chicago, of course. Welcome, Natasha. Today, we're talking about data that's been presented recently at the HFSA meeting, and it's surrounding analyses from the ATTRibute-CM clinical trial. This was a study that was published nearly 2 years ago at this point, January 2024, looking at probably the last placebo-controlled clinical trial in ATTR-CM. We randomized 632 people in a 2-to-1 design for randomization to placebo versus acoramidis at 800 milligrams twice daily. For the analysis for safety, it was 632, and we intentionally included a small group of people who had substantial kidney disease, eGFR less than 30. The modified intention to treat analysis, so the efficacy stuff, came from 611 people with eGFR greater than 30, but this is the first study that included anybody with this severe renal dysfunction for safety analysis for any ATTR-CM clinical trials. The study was, of course, very positive with a p-value 0.0001 for the complex primary endpoint, which was Finkelstein-Schoenfeld hierarchical analysis of 4 tiers, all-cause mortality, CV hospitalizations, and that was recurrent CV hospitalization, not time to first event, change in NT-proBNP, and 6-minute walk test distance, change from baseline. So positive results, win ratio of 1.8, and really exciting data that's followed since then. It's a big study, there's a lot of data, and so we're eager to climb in and talk about some of the latest analyses. To start things off, we're going to have a video that goes through some of the data that's presented, and then we'll have a question and answer period.
Transthyretin-mediated amyloidosis, or ATTR-CM, is a rare disease that is characterized by progressive myocardial tissue infiltration with amyloid fibrils that are composed of misfolded TTR proteins. The TTR protein is a homotetrameric polypeptide that is normally synthesized inside the liver and secreted into the plasma as a carrier protein for thyroxine and retinol-binding protein, or vitamin A. In patients with ATTR amyloidosis, tetramer dissociation and misfolding of the protein lead to aggregation and the formation of amyloid fibrils, which deposit in organs, systems, or soft tissue throughout the body. The progressive buildup of amyloid deposits can also lead to organ dysfunction and subsequent failure of the affected organ or system. Patients with ATTR undergo sequencing of the TTR gene to determine if their disease is either wild-type ATTR amyloidosis, which has no TTR gene mutation, or hereditary ATTR amyloidosis, which has an identified TTR mutation. The etiology of wild-type ATTR amyloidosis is unknown. We do know that wild-type ATTR amyloidosis is related to aging and often manifests as cardiomyopathy. Hereditary ATTR amyloidosis is caused by a pathogenic variant in the TTR gene and can manifest as cardiomyopathy or polyneuropathy or a mixture of both. Early intervention is crucial for improving outcomes and quality of life in patients with transthyretin amyloid cardiomyopathy, whether wild-type or hereditary. New data is emerging on the role of stabilizer therapies, in particular acoramidis and tafamidis. Both acoramidis and tafamidis are transthyretin stabilizers that bind to the thyroxine-binding sites of the TTR tetramer, kinetically stabilizing the structure. This prevents dissociation into monomers, thereby reducing amyloid fibril formation and slowing disease progression in both transthyretin-related cardiomyopathy and peripheral neuropathy. Data show that acoramidis is a highly selective TTR stabilizer that achieves near-complete greater than or equal to 90% TTR stabilization, and it is approved by the U.S. Food and Drug Administration for the treatment of wild-type or variant ATTR-CM in adults to reduce cardiovascular death and cardiovascular-related hospitalization. Acoramidis was studied in the ATTR-CM trial. This study randomized 632 patients with ATTR-CM. 421 patients received acoramidis hydrochloride at a dose of 800 milligrams twice daily for 30 months, while 211 patients received a placebo. The primary endpoint of this study was all-cause mortality, cumulative frequency of cardiovascular-related hospitalization, change from baseline in NT-proBNP, and change from baseline in 6-minute walk distance. The data showed that those treated with 800 milligrams twice a day of acoramidis had improvements in all-cause mortality, cardiovascular-related hospitalizations, NT-proBNP levels, and 6-minute walk distance compared to those patients who received a placebo. 18% of the patients in this trial had concomitant tafamidis use, as investigators were allowed to add tafamidis after 12 months. For more information on the outcomes from this trial, please review the following references. Since the release of the ATTR-CM trial, new data has emerged that helps us better understand the effect of acoramidis on all-cause mortality, cardiovascular hospitalization, and biomarkers such as NT-proBNP. In this discussion, we will highlight 5 key abstracts that have recently been presented. Our first abstract is, acoramidis-mediated early increase in serum transthyretin is associated with lower cardiovascular-related hospitalizations and mortality. Insights from the ATTR-CM study. This abstract evaluated the association between acoramidis-mediated early increases in serum transthyretin levels and the first cardiovascular-related hospitalization and cardiovascular-related mortality. Using a standardized clinical assay, researchers analyzed changes in the serum transthyretin concentrations at baseline on day 28 and every 3 months thereafter until month 30. They found that each 5 milligrams per deciliter increase in serum transthyretin levels at day 28 mediated by acoramidis was associated with a risk reduction of 24.5% in cardiovascular-related mortality and 21.2% for first cardiovascular-related hospitalization over 30 months. Of particular interest, the risk reductions for cardiovascular-related mortality and of first cardiovascular-related hospitalization were greater for each 10 milligrams per deciliter increase in serum transthyretin levels at day 28. These findings were independent of the baseline in serum transthyretin levels in treatment groups. This introduces the idea that transthyretin levels can be a marker of disease state and therapy response. They concluded that acoramidis treatment achieves rapid and near-complete TTR stabilization, which results in early and substantial increases in serum transthyretin by day 28. This is associated with significant reductions in the risks of cardiovascular-related mortality and cardiovascular-related hospitalization by month 30 in patients with ATTR-CM. When asked what this study adds, Dr. Natasha Sarswat noted that active research such as this has added prealbumin, or transthyretin levels, to the list of biomarkers that can help us to understand staging and response to therapy. The next abstract is effect of acoramidis on all-cause mortality, cardiovascular hospitalization, and NT-proBNP in variant ATTR-CM. Results from ATTR-CM. This abstract evaluated the efficacy of acoramidis on the composite of all-cause mortality and cardiovascular-related hospitalization, and the levels of NT-proBNP in the subgroup of participants from ATTR-CM with variant transthyretin amyloid cardiomyopathy. These researchers looked at 59 study participants from the modified intention-to-treat population categorized as having ATTR-CM at randomization. 39 of the patients had received acoramidis, and 27 had received a placebo. The three most common TTR gene variants among this subgroup were V122I, identified in 35 patients, I88L, identified in 7 patients, and T60A, identified in 5 patients. They found that acoramidis treatment for 30 months led to a substantial reduction, greater than 50%, in the composite all-cause mortality or recurrent cardiovascular-related hospitalization, all-cause mortality, and first cardiovascular-related hospitalization compared with placebo. This improvement was accompanied by a significant mitigation of the rise in NT-proBNP levels from baseline to month 30 observed with placebo. These improvements were consistent with and also of greater magnitude than the results of the overall modified intention-to-treat population from the ATTR-CM study. These results are consistent with the numerically larger increase from baseline to month 30 in serum transthyretin levels observed with acoramidis treatment in participants with ATTR-CM than with acoramidis treatment in participants with ATTR-WTCM in this study. As shown in the previous abstract, participants with ATTR-CM often have lower baseline serum TTR, although the association between better outcomes and change in serum TTR is independent of baseline serum TTR levels. It's important to recognize that variant TTR is more prone to misfolding and sometimes harder to stabilize than wild-type TTR. The near-complete stabilization effect of acoramidis may be more important for those with HATTR-CM, said Dr. Daniel Judge. The next abstract is, in patients treated with acoramidis, addition of concomitant tafamidis does not further increase serum transthyretin levels. This abstract looked at the effect of tafamidis taken concomitantly with acoramidis on serum transthyretin levels in participants in the ATTR-CM study. In the original trial, 14.9% of participants in the acoramidis group and 22.8% of participants in the placebo group received concomitant tafamidis at any time during the trial. Overall, the median time to initiation of open-label tafamidis was 17.2 months, and the median duration of exposure to tafamidis was 11.4 months. A closer look shows that the median times to initiation in the acoramidis group were 17.8 months, and in the placebo group were 16.1 months. The median durations of exposure in the acoramidis group were 11.6 months, and in the placebo group were 10.5 months. In this analysis, the researchers looked at the change from baseline in serum transthyretin levels for 4 participant subgroups: acoramidis alone, acoramidis plus tafamidis, placebo alone, and placebo plus tafamidis. These data showed that treatment with acoramidis alone led to a 42% greater increase from baseline to month 30 in serum transthyretin levels compared with placebo plus tafamidis. The researchers also noted that the addition of tafamidis to acoramidis did not lead to any further increase in serum transthyretin levels. This suggests that acoramidis alone achieves the highest level of TTR stabilization among available TTR stabilizers. This suggests that the data showing significant improvement in all-cause mortality and CV hospitalizations with acoramidis are independent of some patients' concomitant use of tafamidis, said Dr. Natasha Saraswat. The next abstract is, acoramidis treatment is associated with a lower incidence of atrial fibrillation, atrial flutter events in patients with ATTR-CM, post-hoc analyses of the ATTR-CM trial. This abstract evaluated the effects of acoramidis versus placebo on the development of atrial fibrillation and atrial flutter in patients from the ATTR-CM trial. These researchers conducted 2 post-hoc descriptive analyses to evaluate the impact of acoramidis on atrial fibrillation, atrial flutter. They looked at the occurrence and annual frequency of cardiovascular hospitalizations Due to atrial fibrillation, atrial flutter, the number of patients evaluated equals 611, and the occurrence of atrial fibrillation and atrial flutter treatment emergent adverse events, the number of patients evaluated equals 632. They also looked at a subgroup of individuals with no prior history of atrial fibrillation reported at study entry. The number of patients evaluated equals 264. They found that treatment with acoramidis was associated with a 43% relative risk reduction in the annual frequency of cardiovascular hospitalizations due to atrial fibrillation and atrial flutter compared to placebo. They also found that the relative risk of developing atrial fibrillation and atrial flutter treatment emergent adverse events was reduced by 17% with acoramidis treatment compared with placebo in the overall safety population in the no prior atrial fibrillation subgroup. They concluded that treatment with acoramidis is associated with reduced hospitalizations and reduced adverse events due to atrial fibrillation, atrial flutter, compared with placebo. Atrial arrhythmias are common in patients with ATTR-CM and contribute substantially to morbidity and healthcare costs. The association of acoramidis with a reduced incidence of atrial fibrillation and fewer related hospitalizations highlights another important benefit of this ATTR treatment, said Dr. Kevin Alexander. Our final abstract is, acoramidis reduces cumulative cardiovascular outcomes within the first month of treatment in transthyretin amyloid cardiomyopathy, results from ATTR-CM. This abstract assessed whether acoramidis reduces the burden of cumulative cardiovascular mortality or recurrent cardiovascular-related hospitalization through month 30 versus placebo, with the initial effect seen early within the first month. The researchers analyzed data on cardiovascular-related mortality or recurrent cardiovascular-related hospitalization in the modified intention-to-treat population from the ATTR-CM study, and found that acoramidis significantly reduced the risk of cumulative cardiovascular-related mortality or recurrent cardiovascular-related hospitalization through month 30 versus placebo. This improvement started as early as 1 month and continued to improve through month 30. Specifically, by month 30, cardiovascular-related mortality or recurrent cardiovascular-related hospitalization occurred in 136 or 33.3% of participants in the acoramidis group and 98 or 48.5% of participants in the placebo group. The difference in the mean cumulative events was significant at month 1 and reached 53 per 100 participants at month 30. The researchers concluded that acoramidis significantly reduced cumulative cardiovascular-related mortality or recurrent cardiovascular-related hospitalization compared to placebo over the 30-month trial period. These effects were observed within the first month. The study adds important data on the totality of the effect of acoramidis in patients with ATTR-CM, as well as shows the early and sustained effect of treatment. These observations are important since they reiterate the need for a time-sensitive diagnosis and initiation of therapy in ATTR-CM, said Dr. Ahmed Masri. Our program now continues with an in-depth discussion of this data.
Welcome back, everyone. And isn't that exciting data? A reminder to the audience that there's the opportunity to ask questions, and we're eager to discuss this. To kick things off, I guess I'll ask a question really of each of the members of the panel. What do you guys think of serum TTR level as a marker of efficacy? Natasha, this goes right to your data. What are your thoughts?
Yeah, so I think it's important maybe to first take a step back and think about the biology of TTR amyloidosis. And again, the TTR protein is a tetramer made by the liver that becomes unstable in this disease and falls apart into monomers that then conglomerate in together into amyloid fibrils that deposit everywhere. So when we think about the mechanism of a drug like acoramidis, we're looking at this as a way of stabilizing that initial TTR tetramer. And when we're measuring serum TTR, we're really measuring the amount or concentration of stabilized TTR tetramer. So if we think about what serum TTR represents, and the idea that that is increasing with treatment, there certainly is a correlation that there is a higher level of stabilization and a higher level of regular normal tetrameric serum TTR concentration as treatment evolves. Is that because of the medication? Certainly it's a correlation. It's not necessarily causation, but I think it's favorable and gives us insights, again, into that mechanism of the disease. And when you take a step back and kind of understand why we're looking at serum TTR, I think it makes a lot of sense to use it as a marker of where we are in the disease.
I agree completely. And I think it's a topic that's come under some debate or discussion, and are there other mechanisms that are coming into account? In the phase 2 study, we used low dose and high dose, 400 and 800, and we saw a dose response effect. 400 had, I think, a 36% increase in serum TTR levels on average, and 50% increase with high dose, with 800 milligrams, which was the phase 3 dosing. So I think the questions are, well, maybe there's more production by the liver, and I'm not sure that makes much sense, just because we know what acoramidis does, we know what tafamidis does. They both raise TTR levels by stabilizing the tetramer. Other thoughts?
Yeah, I can chime in. I think that's, it's a great point. And honestly, like, we need a PD marker in this disease. And, I know people say, well, who cares? Just like do this and see how the patient is doing. But ultimately, you can't really wait 5, 7, 8 years to make up your mind if we're diagnosing patients earlier and earlier. I think we still need to do a few more studies to understand if this can be used as a comparative effectiveness or marker of response in patients. But what it's clear at this stage is that you want to see a response to stabilization or even silencing. But what the degree of response should be, how much it should be, and does it actually compare across patients? Is it a yes and no thing? The more you go up, the better, or is it just you need to see it going up and not being flat? And so that all of these, in my opinion, are open questions. But if I had to bet, I think we just need to think through, as you said, like if there is a clear dose-dependent response there, how can this be affected? And the thing to keep in mind for our audience is that this is meant to be done over a short-term period, meaning if someone is having worsening heart failure after 2-3 years, this value then cannot be used as saying that, for example, the drug is no longer being effective, because as you have, it's a negative acute phase reactant. So we try to use it. The data that was presented usually is using short-term response that if someone is stable clinically will also be reflect long-term response. But if someone is getting sicker, you will see that level be dropping back, to even lower than when you started despite therapy.
Kevin, Stanford's a site with lots of TTR biology experience. Are you guys doing Western blots or anything more fancy than serum TTR levels, or what's your best test for response to therapy?
Yeah, Dan. I mean, clinically, serum TTR. There's some things that our lab and others are trying to look at to see kind of more of the pre-amyloid species. But I think that totally agree with the comments from Natasha and Ahmed that from a clinical standpoint, the couple things I'll just add. I think that a lot of our patients, when they start therapies, they want to know, are the therapies working? How do you know that it's the drug's doing what it's supposed to? And I think for that, in addition to everything else that was said, is something that patients resonate with. You start the medication, you check labs, it goes up. Like Ahmed was saying, the degree at which it goes up, I think, is still under need of further investigation. But I think it's a nice thing for patients. And then I think in some ongoing studies, I think it'd be interesting to see more detailed data with real world evidence generation or prospective studies to see changes in serum TTR levels as it relates to different variants. The data attribute looks like the variants get to a similar TTR level that approaches what we see for wild type, even though they start at a lower level. But I think looking at some of the more uncommon variants would be interesting to see if that's kind of uniform across the board.
Perfect segue to the next abstract that was presented in the video. Jan Griffin wasn't able to join us this night, but she looked specifically at the population with hereditary ATTR with three components of the primary endpoint: the all-cause mortality, CV hospitalizations, and change in NT-proBNP in the variant population. Obviously, it worked well. It worked very well in that population. Let's turn it around and go backwards. Kevin, this is more in your area of expertise. You've done some nice work on hereditary ATTR-CM. Should we ignore this small group, or is this small group enough to have data, to have meaningful data? What are your thoughts?
Yeah, I mean, I think that certainly looking at a larger data set, it's going to be important, but I think it's hypothesis generating. Outcomes in this variant population tend to be worse. It's a more rapidly progressive disease. The V122I variant is the most prevalent in the US. So from a public health standpoint, Scott Solomon, Senthil Selvaraj, and others have done nice studies to show the burden of heart failure and mortality in the V122I population. So I think it's very encouraging to see that not only in a wild type population, but in some of these more aggressive forms of the disease that you see benefit.
Other comments?
I'll just add, I certainly see a pretty significant hereditary population where I am as well. And one of the challenges with all of these trials is that we're enrolling so many wild type patients that as we discuss the results with patients, we always want to make sure that we can apply these results, right? And that it's worth, that these are going to hold in real life. And I think that's the challenge. So certainly, again, I think as Kevin said, the data is encouraging. And it's nice to be able to share with my patients who do have hereditary amyloidosis that they almost essentially hyper-responded, especially those V122I patients. I don't know if we should call it hyper-response, but I do see that they go from a pretty significantly low and really go to normal. And we see that in real life as well. But the numbers are small, so I don't want to put too much stock into it. Though, again, very encouraging.
Great. We can move from there to the combined acoramidis tafamidis analysis in the serum TTR levels. This was Matt's work, Matt Maurer, also not able to join us tonight, but it's really something that people are asking me all the time. Can you compare acoramidis and tafamidis? Ahmad, how do you answer that question when people are asking?
So I think that really feeds into what we have been discussing all along. One is when you have multiple drugs with hard outcomes and endpoints of mortality and heart failure events and urgent hospitalization and whatnot, I think the fair thing to say is that you want to see data attempting to look in a similar population at these two things, at these two drugs in comparable populations. And I think that's totally fair. So that's one way of thinking about it. The other way of thinking about it is can you use, for example, TTR as a way to be a surrogate for the dose response and the magnitude of efficacy of a certain drug? And I that's where I think the jury is still out on that, because what we need to connect is, can we connect the degree of increase in serum TTR regardless of how that increase happens? Tafamidis, acoramidis, or diflunisal, or whatever mechanism you want to use, does that on its own correlate to outcome regardless of the drug? Or is it actually the drug that you use is what correlates with the outcome? And I think that's not clarified or clear at this stage. But I think it is actually promising, and I think it is a good thing that we're seeing that you can increase that serum TTR by this much, because that essentially means, if you flipped it on the other side of things, if we said that we have these stabilizers that can improve outcomes, and then we show that we don't influence the serum TTR, then we would be spinning, our wheels and say, okay, so what does that mean? And then we say, oh, maybe it's not a reliable test. But now we have the other problem, which is we're seeing variations in how this serum TTR responses. Can I use that in my individual patient? I honestly think that we are at a point where we could potentially use it as a marker of lack of response. But I'm not so sure we're ready to use it as a marker of the degree of response.
If I'm hearing you correctly, it's almost a call out to the ATTR-CM study to if that were data available. And I don't remember doing serum prealbumin levels in ATTR-CM, but as you said, hard to compare drugs. There's a clear association with a higher level of effect with acoramidis, but it would be nice to see outcomes in a larger population with tafamidis.
Agree. I agree, and I think honestly that goes beyond stabilization.
Yeah.
If we're saying that TTR is a marker, is in the intermediary marker, I think every single clinical trial and every single study in the past and going forward should be obligated to report essentially data on what happens to that marker, the same way we ask for NT-proBNP, the same way we ask for other markers as well.
Yep. Other thoughts on serum TTR levels are we've had a lot of points on that so far, and it's certainly exciting. I think as the next abstract that came up, Kevin, it's yours with the AFib data, which, gosh, is that exciting from my perspective. I'm not sure we can call acoramidis an antiarrhythmic drug yet at this point, but the correlation is really nice. You want to tell us more about your thoughts there?
Yeah, I mean, I think it's very nice complementary information to what we know about amyloid therapies, and particularly acoramidis for reducing cardiovascular hospitalizations, heart failure hospitalizations, atrial fibrillation, something that 70% approximately of ATTR patients have, and confers a lot of morbidity, whether it relates to hospitalizations and leading to heart failure decompensations. But there's also the symptomatic burden that can affect quality of life. Some patients are very symptomatic in atrial fibrillation. And there's also downstream implications for need for cardioversions and ablations and the cost and risk associated with those. So if there's, if ATTR treatment and acoramidis treatment can reduce the incidence of recurrent AFib, I think that that's impactful for patients. And for those who haven't had an episode of atrial fibrillation before, preventing the onset of new atrial fibrillation, I think that that's also terrific. And so particularly as we start to identify patients earlier and treat patients earlier, we're going to see more patients where we're managing the atrial arrhythmias and early heart failure rather than what we've kind of contended with for years, which is more advanced heart failure, cardiorenal syndrome. That'll still be there, but I think we'll have an increasing proportion of patients who have relatively mild heart failure but are dealing with atrial arrhythmias and the morbidity associated with them.
One of the things that struck me about the data that you presented was the benefits were not only present in the non-AFib baseline population, but the AFib baseline population had less AFib with acoramidis. Really in a population we know is going to recur, right? Like that was really striking to me. Natasha, how are you handling AFib in your amyloid patients right now? Is it reach for acoramidis, or do you have other strategies?
No, I think this was really interesting data, and I think what I was going to say is, initially you think acoramidis again is just slowing progression. Why does that? Is that just a healthier population so they have less fib, or is there less AFib, or is there something more there in terms of lowering left atrial pressures? Is there something more there in terms of less of a strain in the left atrium? And a lot of kind of interesting thoughts in the hemodynamics and the imaging realms of this, of why this could be happening. So how I'm handling it, certainly I think this is a challenging question. And interestingly, a group of us, Ahmad and Kevin, were both with me this past weekend at the national ASG meeting, the Amyloid Support Group meeting. And I will say one of the number one questions we got from patients was exactly this. How do you handle the AFib? Should I get an ablation? Should I not? And I think it really comes down to how long somebody's been in AFib and how symptomatic they are. If there is a patient that's been in AFib for 5 years, is it worth going through an ablation? No. If it's somebody that just is, paroxysmal, going in and out, and they're pretty early on in their disease, perhaps there still is a role for things like ablation. with this data that Kevin showed, I'm not at the point that I would say I'll reach for one drug over another in terms of stabilizers based on whether or not the patient has AFib, but I think it's, food for thought there too.
A great question from the audience, and I'll pass to all of the panel, but does acoramidis need to be used for a lifetime to maintain these effects? We've seen some nice effects. They're quick effects, but what do you do in terms of duration of therapy? I'll ask you, or Natasha, yeah.
Sure, I'm happy to talk. Yeah. I mean, certainly right now, it is a lifetime therapy, and or until the next thing comes along, until we understand the utility of things like our antifibril therapy that have potential to cause reversal. Again, we're still not at the phase that we really understand if this stops working, do we add or change to a silencer? These are all the questions that are still up in the air that I think we're all working on actively. So the short answer is for now, yes, forever.
Another really good question from the audience about measuring TTR levels, right? We're talking about prealbumin, that's covering everything. Isn't there a way, as the question comes through, isn't there a way to tell misfolded TTR from intact TTR? It seems like the TTR level isn't as important as the amount of misfolded TTR. And I think as I look at it, what we're inferring is that there's less misfolded if there's more total prealbumin. But what are your thoughts? And panel members, Maud, I think you're the person who has not spoken in the last couple of questions. So what are your thoughts?
Sure. So that's a great question. Actually, it puts back into the space the issue of these assay developments. So the ones that are commercially available were not developed under rigorous conditions that actually tell you 100% that you're measuring what you're measuring. These generally are monoclonal antibodies. They will bind to whatever they bind to, and then they use how turbid the solution becomes as you mix these together, and that essentially creates a chart or a graph that tells you what's your expected level to be. And so pretty basic. They've been around for a long time. Every sponsor or every company who makes their own drug, especially with the silencers, for example, but also the stabilizers, they actually try to validate their own assay as part of their package when they go to regulators. But we have no access to those. And so it's not necessarily that these all are apples to apples, but that is supposed to be your total TTR level. Now, by increasing the level, we expect an indirect effect that we're decreasing the amount of destabilized TTR. So you're decreasing the dimers, you're decreasing the monomers, you're decreasing essentially that downstream effect. That's the expectation. Now, there are two groups that have produced investigational assays that are not FDA approved, and they're not on track to becoming in any of our labs anytime soon. One is Jeff Kelly, who has an assay for non-native TTR species in patients with variant disease. So these are good for V30M polyneuropathy, for other variant polyneuropathy. They've shown that they can't actually find them in patients who have cardiomyopathy. And so whether that's like a specific thing or not, it's unclear. And then Lorena Salizes Gomez, who is at UT Southwestern, developed also, and we've collaborated on this together, an assay that looks at these species that are supposed to exist in patients who are having destabilized TTR, and it should, try in the future to correlate this with outcomes, response to therapy, all that stuff, but it's pretty early on. So the short answer is actually there is no mechanism to reliably measure all the species of TTR in the circulation. The only thing right now we can do clinically, and even sometimes investigationally, is looking at using a polyclonal antibody, looking at total TTR that we can grab in the serum.
Yeah, I think it's an important point, as you said, the clinical use, right? Because Jeff has published a lot in this area. He's clearly a world's expert in TTR biology. And the three assays that I'm familiar that he's used are Western blot, which is denaturing. And if you really put things in a very denaturing condition, the tetramer falls apart. And measuring how drugs work in that context is less clinically relevant and certainly not available. the fluorescent probe exchange assay. If the tetramer is really tightly bound, then the fluorescent probe isn't going to bind to it. If there's a steady state and some instability of the tetramer, it will, but it's not as good as what Jeff has described as the gold standard, the subunit exchange assay. And that subunit exchange assay is the one that he's published on, comparing acoramidis and tafamidis, and showed a fourfold difference in terms of TTR stabilization, with acoramidis being better. That's in vitro. It's not in clinical use. So I think there's a lot to be learned in clinical practice as to tafamidis versus acoramidis, or even silencers, which we're not even talking about at this point. We've got one more abstract to touch on, and this is yours, Ahmad, the cumulative cardiovascular outcomes improving within the first month of treatment with acoramidis. What are your thoughts? How does it work so quickly?
Yeah, I was excited about this abstract. This is post hoc. It's not pre-specified, but honestly, like any clinical trial we run in cardiology, we expect to be looking at cumulative events in the end of the day. And so, and I think it's important because a lot of different trials are going after cumulative events, not time to first event. And that becomes important if you want to try to like have an idea of what is the effect of a drug over that follow-up period, which is 30 months. And what we show is that with all these cumulative events, we're talking about essentially, of course, there is some autocorrelation between these patients, but if you take these events as events, you need to treat two people to prevent one event. And so that's over the 30 months. And so because you keep accruing these over time. And the other thing that came out of that study, as you mentioned, Dan, is the fact that you do start to see an early treatment effect. Now, it's not going to be statistically significant on its own, but the accrual of these events actually is happening early, to the point where by 6 to 6, 7, 8 months of that follow-up, you have almost a third of your events happening in that initial period. Now, it might not be necessarily always everything to do with TTR. I mean, we know that acoramidis, for example, has a hemodynamic effect. It does decrease the GFR a little bit. Whether this is favorable or not, probably favorable based on what we're seeing here. If I asked you the question 5 years ago, do you expect a drug that you give acutely for TTR stabilization to have an effect within few weeks or within 2 months? I think you would have said probably no. And that's why, I'm really stressing the fact that we need to look into this. And I'm not so sure that this is only explained by the fact that the patients were untreated, because we've never expected to give someone a drug, even untreated, and see something happening at 1 to 2 months. And here we're seeing that. So, I'm excited about this. The takeaway message from me, though, to everyone, is that this confirms that you need to try and diagnose patients quickly and try to initiate therapy quickly. And I think that's, to me, the takeaway, really, if you want, because the rest of the stuff requires confirmation since it's all post hoc. But if you really want to take one thing away from this as well, aside from the early effect of the drug, is the fact that this is not a disease that patients should spend 12 months getting their echo, PYP, MRI, biopsy, this and that. You should actually shrink that time as much as possible.
Yeah, very exciting. And I think it's great to see in a clinical trial that's successful that everything that's looked at has been successful. It's not one thing's going down, one thing's going up, and you're not sure what to say. But like you said, the trends are all in the right direction. They're early, they're starting early, but achieve significance later. We're getting close to the end, and I'll give everybody a minute or so to wrap up with their closing thoughts on where we are now and where we're going with ATTR-CM. Kevin, we'll go alphabetically and start with you and your take on the data that was presented at HFSA and where we're going.
Yeah, I mean, I guess briefly, I'd say that these subgroup analyses and post hoc analyses are really going to be key to furthering our understanding of the biology and natural history of the disease. I think for many years, our understanding of the pathogenesis of amyloid was pretty stagnant, and there's been so many things that we've learned in the last 2 or 3 years. And so, I think it's a really exciting time. You go and give a talk and you have to change half your slides almost, it seems like, just with how many developments there are. So to me, that just opens up a lot of questions. I think there's a lot of opportunity for real world evidence generation and collaboration among our amyloid centers to answer some of the questions that probably won't get answered in a traditional clinical trial.
Thank you. Ahmad, closing thoughts?
I agree. It's honestly amazing to be living through this, revolution in a way of this, from an ultra rare disease 10, 12, 13 years ago to becoming a more commonly encountered disease, to becoming from deadly disease to a more, treatable, manageable, addressable disease. And we'll see what happens with the depleters, but that can even be the next push, in the further direction of actually reversing what's been done and happened. And so I think we're lucky to be part of it. And I totally agree with Kevin, is that we need to do comparative effectiveness analysis. We need to have some data to guide us on how we treat our patients, aside from just, going over what we have available in terms of evidence from trials. A quick reminder that I always use this thing, which is the number of patients that were treated with tafamidis high dose in ATTR-ACT was about 170 or 175 patients. So far, just in the United States, there are close to 50,000 patients that have been treated with tafamidis. Globally, much, much, much more. And so, there are so many things that we can learn from our real world use of these drugs that trials that are looking only on an effect size of treatment will not answer.
Natasha.
Very well said by both Kevin and Ahmad. So, I mean, I guess I'll just add, again, very exciting time to be where we are, both as, scientists, clinicians, whatever you call us, amyloidologists, but certainly also, just what a breath of fresh air for the patients, right? And that's what it comes down to. The way that my clinic goes, yesterday compared to how it was 6 or 7 years ago is just night or day different. It is so amazing to be able to offer options, to be able to get into these nitty-gritty details with the patients, where we can say, look, we're affecting not just the mortality and keeping you alive. Now we're also able to look at things like, again, quality of life, keeping you out of the hospital, the AFib, potentially the myopathy that comes with muscle mass with all of these patients as well. So, lucky that we're evaluating all of these new treatments, and such hope for our patients too.
Well, thank you to each of our speakers. This has been a really great session. Thank you to the HFSA for hosting this event, and thanks to the support. The program was supported by an independent medical education grant from Bridge Biopharma, and thanks to everybody who logged on and listened tonight. Good night.